Wonderful. Do you see that now?
Yes, yes.
Wonderful. I wanted to say thank you so much for having me. It really is an honor to be part of this prestigious faculty. And, thank you to the organizers, especially to Dr. Namrata Sharma, who is a friend of mine, and I've had the honor and privilege of watching her operate. She's an amazing corneal surgeon and a wonderful teacher and amazing mentor. So, and the rest of the faculty, of course, thank you all for having me here. So we will start today's talks on the ocular surface optimization, which I think is really one of the most essential things to getting all of the IOL power correct, because really if you don't have a pristine ocular surface, everything else, really none of the formulas will work, and it just becomes a challenge from there. So let me see if I can go on here. These are my financial disclosures. I'm a consultant for several of these companies. So I'm going to start the talk with a case. This is a 76-year-old woman who presented to our clinic with blurry vision and glare and said, doctor, I have cataract. I've been told I have cataract and I want cataract surgery. My friend no longer wears glasses. She has this fancy intraocular lens, and that's what I want. And her symptoms correlate with cataracts. She has poor night driving vision, but she also says that her vision gets worse at the end of the day, especially after reading and watching TV. And when we ask her, how do your eyes feel? She says, fine, doctor, there's no problem. And she has no other symptoms. So we start our examination. Her visual acuity is down. She does glare. So all of this is consistent with cataract surgery. But when we go to look at her ocular surface and exam, she has significant meibomian gland dysfunction, very thickened secretions, minimal expression of her glands with significant punctate keratitis of her ocular surface and a very rapid tear breakup time. And of course, she does have a significant cataract as well. So I was part of this committee, the ASCRS Cornea Clinical Committee, when we sort of thought about how do we set more guidelines to really capture patients within this preoperative setting who have ocular surface disease. And how do we start? Not every practice will have all of these different diagnostic tests, but what are some of the essential ones to help us identify ocular surface disease in this patient population? And then where do we go with treatment, especially because each patient is individual, each patient will have their own constellation of signs and symptoms, and how do we really gauge our treatment once we have identified these patients? So I know this is a very detailed slide, but this is sort of an overview, and we'll do an overview of what these guidelines really tell us. One of the essential things to remember is that dry eye disease, ocular surface disease in this patient population, to potential errors in preoperative measurements. Topography can be incorrect, keratometry, refraction, aberrometry, all of those measurements, if you don't really have a good ocular surface, will be incorrect. And besides that, we do know that dry eye disease, blepharitis, for example, will increase the risk of surgical infection rates. Surgery itself will worsen dry eye disease. So if you can turn a patient who was asymptomatic dry eye disease and turn them into a very symptomatic dry eye disease if you don't address this before surgery. And the patient will often contribute that to a poor surgery. So even if the surgery went wonderful, they have a great lens, if they feel worse after surgery, they will say, doctor, you did something wrong because now my eyes feel terrible. So it's so important for patient satisfaction and post-operative outcomes to really capture these. Now, the other interesting thing is that most patients in the preoperative setting will be asymptomatic. So these patients, this is a study, several studies actually have shown this now, but up to 60% of routine cataract patients were asymptomatic, yet 50% of them had central corneal staining. So a significant majority of patients in this preoperative setting will present, they will be asymptomatic, yet they will have signs of ocular surface disease. So, one of the things I do routinely, and I really urge all cataract surgeons to do, is to have some kind of a questionnaire in the preoperative setting to be able to capture patients who might otherwise not contribute their symptoms to dry eye disease. And we use the SPEED2 questionnaire, which was also we had adjusted that a little bit to include questions that might help us gauge whether the patient is a good candidate for something like a multifocal intraocular lens. But ask the patient and really delve into these questions to identify. So at this point, if we've seen ocular surface disease, I think it's important to stop the cataract workup and further evaluate the ocular surface to really be able to categorize the severity and the type of dry eye disease in these patients. So the look, lift, pull, and push, LLPP, very important. Look at the lids, look at the ocular surface, lift the lids, look under the lids, pull, look for things like lid laxity, and then push on those meibomian glands to look for the quality and the rapidity of the secretions from the meibomian glands. And of course, we stain the ocular surface as well as part of this to assess for ocular surface staining with vital dye. And here, again, this is just a short video demonstrating, so important. Sometimes you can't really assess by looking at the lids themselves. They may look fine, but if you really delve further and push on these glands, you realize, as you can see there, that they are really inspissated and the lipid layer is really of poor quality. So we did an initial IOL master, had been done before the patient got into the room with me. And you can see one of the other red flags in this is that there's a big difference between the keratometry between the two eyes. So you see very less than 1 diopter of astigmatism in one eye and over 2 diopters in the other eye. That should also send up some red flags. And this patient specifically wants spectacle freedom, so maybe wants something like a multifocal intraocular lens. So given this significant ocular surface disease, really don't trust the initial biometry measurements and further evaluate the ocular surface. How do we do that? Certainly a point of care testing is great if it's available to you. Looking at tear film osmolarity can certainly help identify patients who have tear abnormality. Our patient had an osmolarity in the right eye of 318, left eye of 306. And again, that puts the patient on this scale of dry eye disease. The intraocular variability is also another red flag. I like to look at a tear film inflammatory cytokine markers as well. The MMP9 test is great. Our patient here again was positive for MMP9, telling me that there's an inflammatory component to the tear film. And I love meibomian gland imaging. If you have this available to you, I think it's so critical. And the patient loves to, I think, and will help get them on board with their disease state because they can really understand, yes, this is normal. And this is, my lid looks abnormal. I can see where I have meibomian glands that are shortened, that are thickened, and areas where there's dropout of clear meibomian gland structure. So our patient had a significant dropout there. And then the topography, finally, look at the Myers. These, if there are irregularities, wavy lines, areas where they're missing, this is another red flag that the tear film is not good and really needs to be further assessed. So what is our treatment? We've now identified our patient as a significant ocular surface disease patient. How do we start the treatment? Where do we start? What do we start doing for these patients? Really, our goal here is to reduce the surgical delay time. So I want to treat these patients aggressively, maybe a multifaceted approach, treatment regimen, so that we can get these patients turned around quickly, the tear film, and get them back for repeat measurements and into surgery. So versus a regular dry eye patients where I may add on things one at a time, in this setting, and this is what the ASCRS algorithm emphasizes, you don't need to go one step at a time. You can really take this multifaceted, more aggressive procedural and prescriptions into your treatment plan to turn around the tear film quickly. So again, now in terms of inflammation, so we have inflammation, we have oil glands that we need to address, and we want to clear up the punctate keratitis on the surface. Lots of anti-inflammatory options. We have our cyclosporin formulations, which we all know well, and there are multiple, even in the pipeline that help sort of in the more longer term help reduce the overall tear inflammation. Lifitegrast may work a little bit faster by working at multiple steps in the inflammatory pathway. I won't go into too much detail in the interest of time. I love steroids in this population of patients for short term because you do get a rapid turnaround of that inflammation in the tear film. I use a loteprednol formulation, but something that is maybe a low potency with a lower side effect profile, certainly, and better tolerated, maybe less preservatives in the formulation. I use something like a 4-week to 6-week taper, again, to really turn around that inflammation quickly. Oral tetracyclines are great as well, especially if there's significant ocular rosacea and lid inflammation involved. Importance of treating the lid margin, the oil gland, I think is very essential because we know the lipid layer is really one of the most important to create that smooth surface for our measurements. So relieving the chronic stasis and obstruction of the glands is really essential to improving tear breakup time. And, I start every patient on hot compresses at home and give them full instruction on how to do that. Despite my best efforts, we know many patients do not do this at home, so compliance is sometimes an issue. And sometimes it's also difficult to really reach the adequate temperatures for sustained periods in the oil glands with just anterior hot compresses. Blepharoexfoliation is great, especially if there's a lot of debris on the lid margin, lid cleansing and ointments. In-office procedures, thermal pulsation type procedures, there are multiple approaches now. I do like to offer these to patients who I think can benefit, again, in the preoperative period from a more rapid expression of those oil glands. So something like LipiFlow, there's iLux, MiboFlow, Tear Care System, all of these essentially heat and squeeze, get those oil glands flowing again. Omega-3 fatty acids, I think there has been a lot of up and down in our understanding of whether or not they help with both inflammation of the lid margin as well as normalizing lipid layer. And I think with more recent meta-analysis that was done, I believe in 2019, it really looked at multiple randomized clinical control trials, that the final decision here is to, yes, they do help with improving both symptoms and signs of dry eye disease. And so I do still recommend omega-3 fatty acids, something like a re-esterified fish oil for patients to improve the inflammation of their lid glands. And then there's adjunctive treatments, things like autologous serum, which has been shown in multiple studies to also help with severe ocular surface disease and dry eyes. You need to have a good phlebotomy lab and a compounding pharmacy to be able to produce a good product, but I've seen a punctate keratitis turned around on the ocular surface very quickly with the addition of autologous serum drops, so I like to use that. Fresh frozen amniotic membrane, self-retaining in patients with very severe punctate keratitis, I think is a good adjunct in certain patients to quickly sort of clean up that ocular surface. So I do use those in some cases as well. So the summary of our action plan is really to initiate a multifaceted treatment, treat the inflammation, the oil glands, and some kind of a regenerative, whether it's serum or Procara, if there's significant punctate keratitis, to turn that around. I re-see these patients in about 2 to 4 weeks to assess how our treatment is doing, if we've turned around the ocular surface, and at that point assess whether or not they're ready for biometry and IOL power decisions and calculations. But I always, I think the other part is counseling and education for these patients is very important to keep them on board with compliance. So our patient was started on loteprednol and lifitegrast. We did a LipiFlow treatment. We started the patient on a course of doxycycline orally, and took them all off of preservative drops and put them on preservative-free artificial tears. And when we compare our IOL master results after 1 month of aggressive treatment, we can see here using the Holiday formula in this case that really it turned around not only the spherical component, but took a patient that we thought might need a toric intraocular lens to not needing a toric in the right eye and a lower power toric lens in the left eye. So we saw a change in the sphere and the astigmatism in the eyes with good treatment of the ocular surface disease. The impact, this is a paper that was done by Dr. Epitropoulos and Matosian on 25 subjects with known dry eye disease based on osmolarity, that the biometry after 3 weeks of treatment had significantly changed. There was a higher variability in keratometry rate pre-treatment and post-treatment in these patients, more than 1 diopter of difference between the readings, and a higher percentage of patients that needed at least a half a diopter change in the IOL power finally after treatment. So really, really essential. We're going for perfection in these patients in terms of hitting the bullseye, as we talked about earlier, and you can't do this unless you treat the ocular surface. So again, importance of patient education, getting them on board so that they adhere to the recommended treatment regimen. And in conclusion, really important to identify these patients firstly, and they won't identify themselves. So it's more important in these patients to look at signs, not symptoms, because symptoms will be lacking in a majority of patients. So look for the signs. And then again, a multifaceted aggressive approach to delay surgical time and improve preoperative biometry. And certainly the last thing we want to do is turn a patient who was asymptomatic dry eye patient who did not know they have dry eye disease and now give them dry eye disease with cataract surgery. The patient often, again, blames the surgeon for that. So we really want to avoid doing that. And so that's my sort of review on how to address these patients in the preoperative setting. Again, I thank you for your time and attention.